Welcome to this week's edition of the Pete Mezzetti Show. I'm your host. This evening's topic is a general overview of the Crohn's and Colitis Foundation. And with me to discuss this evening's topic, I actually tonight have a panel of experts sitting behind me. So obviously everybody knows who I am. I'm your host for this evening. My name is Peter Mezzetti, and I'm going to go around and have everybody introduce themselves. Jasmine, go ahead.
I'm Jasmine. I am 15 years old, and I go to Yale Hospital for IV infusions because I have ulcerative colitis.
Pamela.
My name is Pamela Bergantino. I'm 29 years old. I've had Crohn's disease for the past 3 years.
My name is Dr. Phil Ginsberg. I am a gastroenterologist, and I specialize in the care of patients with inflammatory bowel disease.
And Madam on the end.
Hi, I'm Mary Kate Doherty. I am employed with the Crohn's and Colitis Foundation Connecticut chapter as the Take Steps Walk Manager.
And actually, we'll talk about Take Steps at some time and point during this evening. But as far as what I would like to do this evening to get the discussion started is talk to the two ladies over here about what is Crohn's and colitis and what's your treatment like and.
Well, I have ulcerative colitis, and it's just in your colon, and it progressed really fast, so I go for IV infusions every 6 weeks, and it's helped me feel a lot better.
You feel it, so it helps?
Yeah.
Your treatment helps get rid of the disease that's potentially inside
yeah, it just
your
helps
system.
me feel better.
Okay, good.
I'm also on IV infusions. I go for Remicade every 8 weeks.
Okay.
I started with a lot of arthritis symptoms, but since starting my infusions, I felt a lot better.
Nice.
Yeah.
Nice. Dr. Ginsberg, I was wondering if we can maybe talk a little bit about the Crohn's and colitis and how people find out if they have it, and obviously it's treatable.
Yeah, absolutely. So Crohn's and ulcerative colitis are two forms of inflammatory bowel disease, and this is a common condition. It affects 1.4 million Americans, and both of them are inflammatory bowel diseases, which means that there is chronic inflammation of the GI tract.
Okay.
In Crohn's disease, that inflammation can exist in any part of the GI tract, mouth down to the bottom, everything in between.
Okay.
And in ulcerative colitis, there's inflammation that invariably involves the bottom, the rectum, which is the end of the large intestine, and solely involves the large intestine. It doesn't involve any other parts of the intestinal tract. So these conditions are chronic immune-related conditions. So in ulcerative colitis, for example, we see inflammation of the large intestine that can create symptoms. Patients who develop ulcerative colitis commonly have increased frequency of loose stools, diarrhea, and commonly have rectal bleeding and abdominal pain. In Crohn's disease, it can depend, the clinical manifestations depend on the disease distribution and other characteristics. So for example, with patients who have Crohn's disease involving the small intestine, oftentimes that can manifest just as abdominal pain or increased frequency of loose stools. In patients who have Crohn's disease that involves the colon, Crohn's colitis, it can manifest very similarly to ulcerative colitis. And so the clinical distinction between these two conditions really relies upon a careful clinical history. We take patients' history, they describe their symptoms, and we do selective testing such as blood tests. Oftentimes we'll need to do a colonoscopy or an upper endoscopy to visualize the lower and upper GI tract respectively. Radiography, so we'll use tests like small bowel series or CAT scans or MRIs to assess the extent and severity and distribution of small intestinal involvement. And we oftentimes will take biopsies. So the diagnosis of these conditions rests upon a combination of all of these factors. And then once we make the diagnosis and stage the disease, its severity and extent and distribution, we then talk about various treatment options.
Now, what are some of those treatment options? Are they all operable, or are there some non-operable?
Yeah, that's a great question. So although surgery is a part of the treatment paradigm for both conditions, it usually is not something that we start with. Usually we start with medical therapies. So for patients with ulcerative colitis, for example, oftentimes we'll start with what we call the therapeutic pyramid, whereby people start at the bottom of a therapeutic pyramid with first-line treatments such as what we call 5-aminosalicylates. These are medicines that are anti-inflammatory medicines. They're distant cousins of aspirin. And they work topically, either in formulations taken in pill forms that then migrate down to the large intestine where they release their active ingredient, or in formulations that are administered rectally in the form of enemas or suppositories or foams. And those medicines, when they work, it's great because they're very gentle first-line anti-inflammatory medicines that cool the inflammation that causes the symptoms, thereby inducing and maintaining remission. Oftentimes, we need to sort of step up the therapeutic pyramid to the next level where we need to introduce corticosteroids, such as prednisone. Or we will then sometimes move to an immune modulator. So at its root, both of these conditions, Crohn's and ulcerative colitis, are immune system disorders. So the question oftentimes arises when I'm talking to patients, you know, why do I have this? What is the cause of this? And
well, you just beat me to my next question.
So there you go. And so the cause of inflammatory bowel disease is generally felt to be that there is some triggering event, and that triggering event may be an infection, it may be some environmental factor such as a dietary factor. We know that certain medications such as non-steroidal anti-inflammatory drugs are important. But for whatever reason, in a genetically susceptible individual, there seems to be some triggering event that leads to this overactive immune response, which then causes all of the symptoms and the inflammation that we see. So at its root, it's really important that we understand these conditions to be immune system disorders. So once we graduate from the first-line gentle anti-inflammatory medicines, all of our subsequent treatments are immune modulating by definition.
And now, how long does the treatment usually take? Is it a couple of weeks? Is it a couple of months? Or does it vary on how serious your case is?
Right, so the treatment definitely depends on how serious the case is. These are both chronic illnesses. There's no cure for Crohn's or ulcerative colitis. In ulcerative colitis, there is a surgical option to remove the entire colon, and that's generally that is generally deemed to be curative. However, we oftentimes try to follow a principle of induction and maintenance of remission. So for chronic conditions that don't have a cure short of surgery in ulcerative colitis, we generally treat chronically with long-term maintenance agents. So it's not something that we just give for short periods of time. We try to treat with the intention that people will be maintained on therapy long-term.
And that is is it usually like once a week, once a month, or does it depend on?
Well, it really depends on individual circumstances. So medicines that are dosed by mouth, we can give daily dosed medications. And absolutely. And medications, there are certain medications such as some of the biologic medicines that have to be dosed parenterally, meaning they can either be given in the form of a self-injectable form that's dosed subcutaneously that patients do on their own, or an infused medication that is given periodically, you know, as you see, every 4 to 8 weeks, depending on the circumstance.
Now, you guys have to go in and have your procedures done every 4 to 6 weeks, right? Are there any side effects to having your treatment done?
Right away.
I was going to say it doesn't. I was going to say you don't get, because I know I actually had a procedure done a couple of years ago, and right after I got home, from the medication that they put me on, I was sick as a dog for about 3 weeks.
When I first started my infusions, I would go home and take the best nap of my life.
Yeah.
It's gotten better, though. I can go back to work now.
But naps are good things, though.
Yes, they are.
Naps are very good things. Mary Kate, from what I understand, there's an event coming up.
There is indeed,
Talk to me.
Yeah, we've got our second annual Connecticut Shoreline Take Steps Walk happening Saturday, October 25th at Hammonasset State Park in Madison. So we're expecting 200 or 300 participants to come out, many of whom are patients. Many of our local gastroenterology practices are forming teams. to support their patients as well. So we expect to have a nice family-friendly event. We'll get started around 9 o'clock in the morning. Got plenty of entertainment and activities planned. And then we'll have an opening ceremony right around 9:45 or so, and the walk will kick off at 10.
Now, where's the walk go?
So we're going to be, our festival area is at West Beach, picnic shelters 2 and 3.
Sure.
And the walk is then going to proceed down to the nature center. So it's about a mile, and then we'll have a little water stop and rest stop down there. Folks will turn around and come on back to the festival area. So flat walk, stroller friendly, wagon friendly for the kids. Dogs are welcome as long as they're on leash. But yeah, the walk itself is a flat 2 miles.
Very nice. And how was the? You said this is the second annual. How'd you guys do on the first? Pretty well.
Fantastic. Yeah, we had about 100 people come out and raised just under $20,000. So we are hoping to double on both factors this year, double the number of people and double the amount raised, so we can fund cures faster.
And I was going to say, and all the money stays locally here.
Yeah, well, yes and no.
Yes and no, all right.
We do offer local patient services and patient and professional education programs, but our research program is actually nationwide and in fact globally. So research, we don't necessarily care where it happens. It's going to benefit everybody. So that, as I said, is
As long as it
nationwide.
happens, everybody's good.
Absolutely.
You know what? Would you guys mind sticking around for another segment?
Sure.
Yeah? We'll be right back after a short break.
Professions in the nation, and most people don't realize that nurses, just like physicians, can be nationally certified in their nursing specialty.
Nurses are probably the foremost providers of care throughout the healthcare system. Certification is an asset to the nursing field, and it ensures that nurses keep up with the changes that are constantly coming in healthcare.
As a professional, I really believe that we have an obligation to ourselves and to our patients to demonstrate national competency in our area of specialization.
Being NCC certified was a professional and personal goal of mine. I believe it validates my skills and knowledge while allowing me to give improved care to my tiny patients.
NCC certified nurses make a difference in the health care of women and their children. Learn more. Visit nccwebsite.org.
And welcome back to this week's edition of the Pete Mezzetti Show. I'm your host, sitting here with a esteemed colleague, bunch of people tonight, talking about Crohn's and colitis. So for our viewers and radio listeners who are just joining us, I'm going to open the segment again and go around and introduce everybody. Again, I'm Peter Mezzetti.
I'm Jasmine Gargano. I am 15 and I am a patient at Yale Hospital. I have had ulcerative colitis for about a year, and it started pretty fast for me. And I go every 6 weeks for IV infusion for Remicade.
My name is Pamela Bergantino. I'm 29 years old. I've been diagnosed with Crohn's disease for 3 years, and I go for IV infusions every 8 weeks.
And my name is Dr. Phil Ginsberg. I am a gastroenterologist who specializes in the care of patients with inflammatory bowel disease.
And last but not least,
I am Mary Kate Doherty. I am an employee with the Crohn's and Colitis Foundation Connecticut chapter, and I am leading the Take Steps Walk program.
all right. Well, ladies, just to, again, we talked about this during the first segment. Let's talk a little bit about the disease and about your treatments for my radio listeners and viewers that don't know what Crohn's and colitis is.
Sure.
Well, ulcerative colitis is just a disease that affects your colon, and there's like many different things that will like help your disease. And I was on oral medication. And then it progressed really fast, and so then I was switched to Remicade, which is the IV infusion, which I go for every 6 weeks.
Okay. And Pamela?
I started actually with arthritis symptoms. I had that for years before I finally had the typical like stomach symptoms that they associate Crohn's with. And so now I'm pretty well regulated with the infusions that I do and the Remicade that I go every 8 weeks, and I just try to watch what I eat and stay active, and things are going pretty well. Yeah.
Feeling pretty good?
Yeah.
All right. Dr. Ginsburg, let's talk. So I know you and I talked about this during the first segment of the show, and was wondering if we can talk about it a little bit more. Let's talk about how people find out if they have Crohn's and colitis, and if it's treatable, and obviously if it's curable.
Yeah, so oftentimes people will first notice perhaps a change in their bowel habits.
Okay.
Sometimes people will have diarrhea and crampy abdominal pain. In the case of ulcerative colitis, it oftentimes is fairly obvious when a young person, for example, begins having bloody diarrhea.
Right.
That usually gets everybody's attention fairly quickly.
Yeah.
However, in Crohn's disease, for example, there can oftentimes be a delay in diagnosis because some of the symptoms, depending on the distribution of disease, we talked about the fact that sometimes it can only involve, for example, the end of the small intestine.
Right.
And when that happens, the symptoms can be subtler. They can just be crampy abdominal discomfort, which in, for example, an 18-year-old may be misinterpreted by a family practice doctor or a pediatrician as being irritable bowel syndrome, which we know is very common.
Correct.
And so we look for alarm signs. These are things that ring our bell, things such as rectal bleeding or unintentional weight loss in children if they fall off of the growth curve. Oftentimes we see extraintestinal manifestations. So Crohn's and ulcerative colitis aren't just diseases of the intestinal tract. There can be a lot of other manifestations, and that can include joint symptoms.
Yeah.
That can include eye manifestations such as iritis or episcleritis, a red painful eye with blurred vision. Sometimes we see problems with skin, so we will see patients who have what they think is a spider bite that ends up being something called pyoderma or erythema nodosum. So there are all different kinds of extraintestinal manifestations that can occur. So for folks like me who are really interested in taking care of people with these conditions, we recognize that they're not just diseases of the GI tract, they're really diseases of the entire body.
Now, if someone says, now somebody thinks they have Crohn's and colitis, by those symptoms, they should obviously go see their doctor, and then their doctor sends them to someone like yourself?
Yep, absolutely. So if you're a patient and you are having symptoms and you're not sure what they are, it's important to get checked out. Yeah.
Right. And then they call you, and you obviously check them out and do all your...
We do our thing.
You do your thing.
So we take a careful history, we do blood tests, and you know, most people usually end up with a colonoscopy.
And that's probably the lesser of the two. That's probably the most. Is that one of the most effective ways to?
That's a very high yield
catch it?
test. Yeah, absolutely, because we're able to visualize the entire colon as well as the end of the small intestine, and so that by itself oftentimes can give us the answers that we need. But like I said, the diagnosis rests upon a combination of clinical, radiographic, endoscopic, and histologic and laboratory findings.
And it usually, it's not. You can't figure everything out in one day. It usually takes a couple weeks to figure out.
Absolutely.
From start to finish.
Sometimes it's very obvious, and sometimes it takes a little bit more work. But we eventually figure it out.
Exactly, and then once you figure it out, you figure out what the next step is as far as if it is a medication or shots or oral medication.
Yep, you got it. So first we make the diagnosis, and then we talk about treatment options.
And how normally treatment options? How long does it take? Take a couple of years? Take a couple months?
No, we really try hard to get people feeling better fairly quickly. So it depends on the individual circumstance, but most of our medicines are designed to induce remission.
Okay.
Usually within a period of, for example, in the case of prednisone, we can get people feeling better fairly quickly, reliably, usually within 72 hours, although that's not, a long-term solution.
Right, exactly,
that's just
no.
a Band-Aid. And some of our other medications, such as the newer biologics like Remicade or Humira or Cimzia or Simponi, these are all medicines of a class of biologics called anti-TNF agents.
Okay.
These medicines are designed to work Also fairly quickly. Usually we see early responses as soon as the first treatment, but we really like to see improvement certainly within the first 6 weeks, and by week 12, patients really should be in remission and off of steroids. So that's the general timeline for induction of remission.
Are you going to be at the walk?
I will be, yeah.
You will be?
Yeah.
And speaking of walk, we'll talk to me about a walk.
Sure thing.
October
So,
25th, I believe.
Saturday, October 25th,
All right.
Hammonasset State Park in Madison.
Okay.
We've got a great event planned, very family-friendly, family-oriented. Pamela has actually been serving as our entertainment chair and has a great lineup for everyone. And, you know, we'll have a DJ there, we'll have refreshments. We'll get to hear from some of our patients.
Okay.
They'll be sharing their story. We'll do some team recognition, some of our sponsor recognition. Pfizer is one of our local sponsors. We're very grateful for them.
Thank you.
And the walk itself is a nice 2-mile stroll, flat, family friendly, so you can bring the strollers, bring the wagons. Dogs on leash are welcome in the picnic area and on the path. They're just not allowed on the beach at that time of year. So, but yeah, folks, you know, we really encourage folks to come out. It's going to be, you know, a great morning.
It is, it is. So, Madam Entertainment Chairman, talk to me. What do we got on tap?
We're going to have some pumpkin painting, and you can put stickers and all kinds of stuff on pumpkins.
All right.
Because it's the weekend before Halloween.
It is. That's right. It is the weekend before.
We're gonna have some face painting.
Okay.
And we're gonna have a photo booth and all kinds of things.
And obviously, it's not too late if people want more information or want to get involved or want to form a team. Is it? I hope it's not too late.
It's absolutely not too late
All
now. We welcome folks to come out. You can go to our Crohn's and Colitis Foundation website, which is ccfa.org.
Okay.
And from there, click on Get Involved, and you'll see Take Steps as an option. And then just enter Connecticut, and you'll see all of the walks listed in Connecticut.
Now, as far as the website goes, what other bits of information can people find?
Sure. So once they're on our Connecticut Shoreline Walk website,
Okay.
we have the map route posted. We've got some shout outs to our teams, plenty of resources in terms of folks who want to join us and want to fundraise, which we greatly appreciate.
All right.
So a lot of resources to help them do that, help them recruit their family members and friends to join them. You know, we encourage folks to bring as many folks with them as possible. It makes the event more fun for each group, and obviously the more people we get involved, the more funds we raise, the quicker we can fund research to find cures.
Now, as far as this is the second year, how did you guys do last year? Pretty well?
So last year we did do well. We had about 100 people, registered participants, show up and raise just under $20,000.
Very nice.
Yeah, so this year we're expecting to at least double our number of people and hoping to double the financial resources we bring in. So our goal is $40,000.
How many teams we have so far?
So far we have 36.
Wow.
Yeah, 36 teams, about 150 people registered.
All right.
So we are well on our way.
Can you register up to the day of the event, or
You can.
Do you want people to just pre-register?
We definitely prefer that people pre-register because it helps us plan all of our logistics. We want to have enough refreshments for everyone. So it definitely helps us with the planning process, but it is open to the public and people are more than welcome if it's what we're hoping to be a nice weather day that Saturday morning.
Exactly.
Come on down to Hammonasset. You can register right then and there.
And what time's registration start?
We'll get started right around 8:45.
Okay. Yep. And if people want more information on Crohn's and colitis for Connecticut, where should they go?
CCFA.org.
Okay, and then just drop down to the Connecticut.
Yeah,
Just
from that
drop down.
website, you can find our chapter website, you can
Okay.
find our walk website. So it is a wealth of information. There's tremendous patient resources there, as well as, you know, ways to get involved if you're looking for a volunteer opportunity.
And obviously, you guys are always looking for volunteer opportunities.
Absolutely.
And
We are, we are a volunteer-driven organization.
You are a
We
volunteer.
could
Yes, you are a
not-
volunteer.
Could not do what we do without volunteers. So they are the glue that holds us together and the engine that keeps us moving forward.
Exactly, and hopefully we get a good Saturday.
Exactly.
The weather's going to hold out. Weather's not going to be too hot, too cold.
Yeah, we're hoping for a nice Indian summer.
We
Morning, yeah.
could live with an Indian summer morning. Again, before we say well, you know what? Before we say goodnight, that's it. That is goodnight. On behalf of my esteemed colleagues, I'm Peter. Thanks. Good night, and we'll see you next week.